Welcome. Hello, hello, hello. Hello, hello. Yay. Hi, Lenore. I
Hi,
like it when I'm good. How are you?
I'm hanging in.
Hanging in. All right. We made it
Watching
through
this
another
to
week.
find out what's wrong with me.
Okay, well, good. Well, you're in the right place because you're going to get to listen to Dr. Samanta. So I'm going to welcome everybody. We have a lot on the agenda for today because it's a very popular talk and something I think we don't talk about nearly enough. So I'm super excited to have him with us. I've known him for years, and he is just one of the most special movement disorder physicians because he not only is fun and practical, but he just cares so deeply. He just really is just such a human-centric forward person. So I'm so glad you guys get to hear from him today. I'm Sarah Jones. I'm the CEO of PMD Alliance, and I'm going to host our conversation today. Today's will be recorded, and we're going to invite you to unmute yourself and ask questions and make this a really interactive conversation. We're going to hear a little bit from Dr. Samanta about some of these topics, but then we're going to want to hear from you and ask and answer your questions. See, we've already got a question coming, but I'm going to tell you really quickly about Dr. Samanta. So let me tell you a little about him and read you his bio. So Johan Samanta is a board certified movement disorders neurologist in private practice in Phoenix, Arizona. He's a clinical professor of neurology at the University of Arizona College of Medicine and has a clinical lecturer at the Phoenix Medical School campus of the University of Arizona. Dr. Samanta received his medical degree from the Medical College of Pennsylvania before completing an internship in internal medicine at St. Joseph Hospital and Medical Center and a residency in neurology at Barrow Neurological Institute in Phoenix. He completed his postgraduate training at the Evelyn Kosak Movement Disorder Fellows at the Muhammad Ali Parkinson Research Center at the Barrow Neurological Institute. His research interests include motor learning and exercise in Parkinson's, non-motor symptoms, surgical and non-surgical management of tremor and dystonia. And he is really one of the leaders in Arizona utilizing therapies to help with dystonia and pain and drooling and other issues that can happen as a part of Parkinson's. So we're just super happy to have him with us today. And I wonder maybe, Dr. Samanta, if you can start by just kind of giving us an overview of what these kind of things are, maybe why they happen, specifically like the dystonia and the cervical and cramping.
Sure. And obviously, first of all, thank you so much, Sarah. You make me seem far more competent than I feel like on a personal basis some days. But I do really appreciate being on. I love the PMD Alliance, and I love interacting with people, patients and or people affected by movement disorders out there. So thanks for everyone for having me. When you mentioned this topic, I thought, gosh, we haven't really ever, I don't recall in all these years really ever sitting down and just sort of discussing this sort of thing specifically. And I was trying to think of, well, how do you cover all this? And I thought maybe it might be good just on a really not exhaustively, but just kind of quickly to run through maybe kind of the different kinds of symptoms or the kinds of muscle tightness, if you will. So the things that, is this a cramp? Is this dystonia? Is this rigidity? What is, that I'm having? And that that can be confusing to patients. Especially there's with some of the more progressive movement disorders like Parkinson's or Huntington's or something like that. But also, is this something I need? Is this a tightness I need to worry about or not? So I thought I could just run through. So on the most mundane kind of ordinary end of the scale, are muscle cramps, right? It's something like 6% of the population, has nighttime, at least has occasional nighttime muscle cramps. That's like all comers. And And oddly enough, as we get older, we do have a greater tendency to have muscle cramps, not just at night, but in general, and these are peripheral things. So they're not governed by the central nervous system. They're happening at the level of the muscle. And sometimes they don't even have to involve a whole muscle. It could be part of the muscle that contracts and then gets essentially stuck in that contracted position, and it can last a few seconds, but it can last, several minutes. And these tend to be really painful. And as I kind of mentioned, I mean, that would be like the classic, you're turning over in bed and all of a sudden your calf locks and you're just like, oh my gosh, I gotta get this, get rid of that. And it seems to be a kind of a mix of things like, maybe we're a little dehydrated. So the electrolytes might be a little off. And so the contraction trigger kind of, for our muscles at the cellular level just kind of gets locked. And as I said, it gets more common as we get older. So, and I was shocked by this number, but over a third of people over the age of 60 have, at least occasional nighttime foot cramps, and so that's pretty darn common. And really there, it's about things like stretching. It's about making sure that we are drinking enough water during the day, especially if we are going to do something, if we have a more strenuous day planned. So a lot of times you may not cramp up during the activity, but later that day, as you get more lactic acid in the muscle and whatnot, and the muscle itself is just a bit more irritable in that. And it's certainly something that, that our people with movement disorders experience, but it may oftentimes be sort of independent of that, of the underlying condition, with maybe the one sort of exception being, I think, nighttime, leg, foot, calf cramping in people with Parkinson's. There, I think there's probably a little bit more of a link to the Parkinson's as well, because in their case, we will actually see that there's taking or increasing your overnight coverage of your Parkinson's meds can actually reduce that, and we can come back to that in a minute. So that's kind of like the most mundane, the kind of the universal type of spasm or tightness or what have you. World-class athletes have this, and world-class couch potatoes have this. So that's one end. And then there's another thing called spasticity. And that's what happens when there's been an injury to what we call the upper motor neuron. So the cortex, in those neurons in the motor strip, and their connections down to the spinal cord. And so we're talking about strokes, head injuries, spinal cord injuries, and things like that. And this is more of a continuous issue. So it's like, so if you've ever seen someone who's had a stroke and they're walking and it affects one side, and what you typically will see is the affected side, their leg, it looks stiffer and straighter, and they often hold their arm a little bit flexed into their side. And that's sort of a primitive default setting, from as we've evolved over the eons and millennia and all of that. And so that if there's an injury, we sort of still have some mobility left. If you had a stroke and you were just, your you just went flaccid, well, you know, out in the wild, you'd really be done. Whereas, you know, here there's still some ability to have some function if that injury wasn't too bad. Now, these days we have physical therapists and we have therapies and other treatments, so that doesn't have to be the end all be all. But a lot of these folks, what they feel is those muscles are really tight and can go into spasm as well because they are chronically a bit tense and tight. And the big difference there is that there's always some weakness, and there is not very good coordination or control because it's actually that pathway coming from your brain telling your arm what to do that's not functioning. So that's why they kind of tend to have a kind of a fixed posture, even though it can get aggravated in spasm. And then more to to the folks that we're talking to is we come down to the other two forms, which is rigidity and kind of dystonia or dyskinesia. And so rigidity is kind of what we see in Parkinson's, and it's related to, you know, a lack or underfunction in the basal ganglia usually from not enough dopamine, but and what's happening there is, you know, is that basically the muscles just aren't able to fully relax at rest. So because that signal in the basal ganglia is a little, you know, isn't as balanced, it's sort of like having a rough idle. So there's a little bit of tension in all the muscles, and that's what leads you not to swing your arm as much if you have Parkinson's, you know, or to take shorter steps. And the like, or maybe to stoop or be a little more curled forward, because it's just kind of always there, and it tends to. We describe it almost as what we would say is waxy rigidity, and then when I explain this to medical students, I'd say, you know, normally when we tell someone to relax, it should feel kind of like a heavy rope, like a really old, nice cotton rope that's just really well broken in. And the only real resistance is just from the weight of the rope itself. Whereas with rigidity, it's kind of like that somebody dipped that rope in wax and now you're bending it. And yeah, it still bends. It's not fighting you, but it's, you know, it's just slower but smooth, you know. And that's what rigidity is. And if it's severe enough, it can, you know, it can be uncomfortable, or it, you know, it certainly can cause some discomfort. It can feel kind of like a Charlie horse to some folks, especially when they're trying to do things, you know, because you're kind of working against more resistance. And so that's, you know, and that's kind of the thing there. And unlike spasticity, where someone's had a stroke and they don't have as much strength or coordination there, people who have rigidity, people with Parkinson's, if you actually test each muscle, they've got good strength in there. And the heart, where they might feel like they're not as strong, is just because they are having to overcome this kind of extra friction. And so it takes a little more work to do the same things. And that's so it isn't unusual for patients to perceive themselves as having some weakness when they have rigidity with Parkinson's, but what they're actually experiencing is just, boy, I got to work harder to do the same thing because I'm actually working against my own rigidity on top of whatever, you know, opening that jar and, you know, or what have you. So that's kind of where rigidity comes in. And, you know, and I guess the other piece of, well, why would, you know, where does that come in with cramping and things is just, you know, if those muscles are a little tighter, they can tend to get shorter. And the shorter the muscle is, then the closer it is to cramping when you do contract it or use it. So there can be some increased cramping just because the muscles are already a little short and tight. And that's why, guess what, things like stretching and exercise become so vital to someone with something like Parkinson's disease. And then the last sort of area where we talk about tone, and the last sort of the fourth kind of domain, if you will, is dystonia. And we could kind of call it dystonia or dyskinesia. So, and that kind of speaks to both our dystonia patients, our Huntington's patients, and our Parkinson's patients. And that's central and involves the basal ganglia again, just like Parkinson's, but it's literally the opposite. So where Parkinson's is sort of, is kind of a less movement or less activity, but in just some basic resistance, dystonia and dyskinesia are really an overflow of movement. So there's muscle contraction and activity happening when you want to be at rest, really. And that's why someone with cervical dystonia, their head is, they're trying to look at their computer screen, but their head is trying to pull, back and to the right or over and to the left, and their shoulder wants to rotate, or someone with Parkinson's who, is at that point in their medication where they're having some dyskinesia. They are not, instead of being really still and not moving very much at all, which would be the under-medicated side, they're kind of actually a little overstimulated and they can't quite sit still. And that could be very mild and very subtle, or, or in more extreme cases, and thankfully not super commonly anymore, but it can be pretty dramatic too and really bothersome. And so that's kind of maybe a way to think of what is the difference between rigidity, or that, kind of the Parkinson's, the undertreated or under compensated Parkinson setting versus dyskinesia or someone with dystonia. And if you think about it, it kind of makes sense that, people with dystonia don't seem to be any more likely to get Parkinson's disease, because it's really the complete opposite of that, and it's not they're not having a dopamine dysfunction. They just have a little bit of they have an overactive circuit is what they've got. So
wow,
that's kind of everything in a nutshell, and then some. Yeah.
That's amazing though. I've never heard the continuum of all of that explained, and I'm going to see if I heard you right. So this is my quick test.
Mm-hmm.
So I heard you say cramping is normal, especially as you get older. Like that's a normal thing, especially at night. We know what cramping feels like, but that may not be tied to anything related to any disease. It might just be because, yay for us, we're getting older.
Yeah. Didn't drink enough water when we were out digging in the backyard that day.
Didn't drink enough water. Go drink some water and then climb back in bed. Okay, and then the rigidity. I loved the wax thing. So the rigidity actually, there's probably like Parkinson's rigidity. There may be very normal muscle tone and strength, unlike spasticity, which is a weakness perhaps in the muscle. But rigidity, you have a lot of muscle tone. It just is rigid. And that can show up in sometimes what might feel like a Charlie horse.
Yeah, so I think patients that are maybe, that are trying to get things done and they have rigidity, you're fatiguing and tightening up those muscles, because the more you work, there's that underlying tension plus whatever you're trying to do. So often there can, people will describe, boy, I just get really sore, or I get kind of tired, at times.
Yeah.
Not everyone, but it does definitely happen, and it kind of makes sense as you think of it. Yeah.
Right. And then, whereas though the dystonia, and I didn't realize this, was really kind of the over, just like dyskinesia, it's like an excessive movement, even though it might look like stiffness and tightness, it's actually a result of excessive.
Exactly.
Interesting. And that's the kind of thing then that your doctor's going to go through to kind of sift through what are we dealing with. Because I'm assuming that they're different treatments, but maybe there's similar treatments that you would end up with.
And because our brain is so almost endlessly, complex. We're only, with all the advancements we've had in understanding how our brain works, we're still kind of scratching the surface. But there are going to be situations where what because if you went just with what I said, there are exceptions to that. So sometimes, people like in Parkinson's, sometimes you get dyskinesia often at the peak of a dose, and what have you. And other times you get the dyskinesia more at the very beginning, at the very end. And it's what your brain is responding to isn't so much like the overall amount of stimulation, but that there's a change in the level of activity going on around it. And that's leading to dyskinesia or sometimes dystonia. And then other times, this thing we call like wearing off dystonia, where you say, well, hey, if it's dystonia and the dystonia and the dyskinesia are supposedly, kind of the same, coming from the same issue, why does it help if I take my medicine earlier if I'm having wearing off? Why would levodopa help my wearing off dystonia? And there, it's probably because that dystonia is really just sort of more of a kind of a rebound rigidity, if you will, or it may be physiologically. And again, it may be more about what's happening on the chemistry level of the brain. And so the Parkinson's kind of model is just, it gets to be a little bit complicated in terms of, it is, there are things, there's the normal, not enough dopamine, too much dopamine, the right amount. And then there are the ways that our brain tries to compensate for the fact that, hey, we're not quite there with making, replacement dopamine act exactly nice and smooth and continuous the way our brain used to produce dopamine. And so the rest of the circuit may become more reactive or more sensitive to little fluctuations than would be normal. We think that's kind of the process by which dyskinesias develop. And because it's an altered response, it probably can be, it's clear it can be a little bit idiosyncratic, which is to say, it can have a little bit of a mind of its own as opposed to classic, really simplistic, high, low, good approach. And that's why I think sometimes, even though you're wearing off, you're having dyskinesia and dystonia, and the answer, oddly enough, becomes more levodopa, not less, in that situation. So I would, if everybody on here says, I don't know what he just said, that's perfectly, I understand, because it's such a weird, complicated thing. And it's,
right.
I think we barely understand it ourselves. So it's hard for us to, I think sometimes it's hard to explain it, because the fact is I think you could just say, it's just a weird thing that happens specifically in Parkinson's. And so you just gotta go with, well, that works. So,
it's the truth, isn't it? Because you're not, these medications and these treatments aren't curing. So we just have to see what works for each person. And you bring up a good point. This is why it's really important to see a movement disorder specialist, because these nuances, you just talked about three things that can look so similar. And, for us to try to describe it to the doctor, even in our very best way, I think is tricky. So, yeah, I think somebody did ask if there are treatments for rigidity.
So certainly for rigidity, I mean, especially as it relates to Parkinson's disease, we believe that the primary cause of that rigidity is the lack of dopamine, and so that is one of the primary goals of being on a dopaminergic drug. So levodopa or a dopamine agonist or any other drug that brings up, and helps replace dopamine. So that's still the number one pharmaceutical, chemical way that or medical way that we want to deal with it. And then in addition to that, I think things like stretching, exercise, isometric exercise and stretching, increased activity, all of those have positive impacts as well on rigidity. Though I think, realistically, it's got to be that combination of things together, both the drug therapy and the activity and stretching.
Activity, exercise, maybe physical therapy. Michael Abrams had a question. I believe that he is unmuted. Michael, I'm going to see if you want to ask your question to Dr. Samanta.
Oh, yeah.
Yeah, I'm typing. I typed it now.
Okay.
My neck will freeze up or just become painful if let me put my, got to get my, there we go. If I turn my head to the right or the left, straight on that way. I don't know if you can see,
Yep.
It's like when I'm driving. It's like I'm able to go to the left pretty far, but can't go as far to the right. And it really hurts right in there. And I can feel it like a wave of hardness.
Right. So now you get to, so I think you bring up a great thing. It's something that probably a lot of people, whether they have cervical dystonia or Parkinson's or even none of those, have to deal with. So there are, on top of the muscular things that are going on, with a movement disorder or just with a life full of activity and work, is there are also, everything's interconnected. So there are the spinal column itself and the vertebrae and the little joints called the facets running down the side of the spinal column of the vertebrae, that sort of where they stack on each other and where nerve roots come out between those little openings. And over time, even without rigidity or dystonia, we're good at collecting wear and tear in those areas. But I think when you throw in having kind of the extra stressor of that pulling of the muscles or the tightness or the change in posture, because of the rigidity, that often adds some wear and tear for folks, in those vulnerable areas, the neck in particular, because it's such a high mobility. It's a fairly it's supposed to be a very mobile area. And so oftentimes you then on top of that get some bone spurring and arthritic kind of changes there, and some changes in alignment that can really restrict or make range of motion more uncomfortable. And so that's a good example where you look and I this is our first time seeing each other here, but I look at you and I go, wow, you look like you've got pretty good mobility and movement, and yet you're having trouble turning to the right or turning your head to the right. And it makes, again, not giving you, direct advice, but this would be a situation where one wonders, well, gee, maybe there's also some, some skeletal, some things going on in terms of some arthritic changes or some, some stiffening there from some calcification.
So you're suggesting an orthopedist?
Not necessarily, but I would say
that's why
if that's a situation where
why you're hemming.
I would often, well before that, I would say,
I don't like surgeons.
I don't either.
Think they can fix it. If you need surgery, you can't get it fixed. Would you recommend anybody else? Any other kind of specialist?
So the thing you want to do is figure out, is it definitely, something there? Because it doesn't have to be a disc. It could be just arthritis changes and some inflammation. Sometimes that's PT. Sometimes that's, it might be, a cortisone shot in a couple of places and some stretching. So it could be so many different things. I always caution folks to don't, let's not jump right off to the, to the maximum
Parkinson's,
intervention. Let's figure out, what if it's just kind of some run-of-the-mill bone sparing and a little bit of stretching and, and some massage therapy and anti-inflammatory use might actually help. So that's where what I'm getting at with a situation like yours is, unfortunately, we still have, all the kind of more mundane things that can cause stiffness or loss of or impairment of our range of motion, especially if there's pain involved. I always think of, well, gee, could this be arthritic in some way? Not rheumatoid, but yeah, kind of wear and tearish. So.
When you bring up an issue, because some people were asking, could this be tied to the spine and different questions like that? And I think the piece that you bring up, and what I appreciate about what you bring up is that it really does take a team, right? Since we really are complicated beings. And I have a quick question though. Somebody sent me a question and I have to make sure to ask you this.
Okay.
Somebody sent a question and said, so now that the damage is done from levodopa, can we repair it by stopping it? Or trying a different track for PD symptoms. So I wanted to ask that because I don't know that you would recommend just stop your carbidopa levodopa.
Right. So
yeah.
And I guess I would say and again, I'm not definitely not here to pick a fight, but I would say I would quibble about kind of the idea that there's damage being done by levodopa. I think the bad guy in all this is Parkinson's, no matter what, and it's just that levodopa is a perfect drug if we had a perfect delivery for it. There is not a shred of evidence, in now over the last 40, 50 years that says, in the real world, in a real human brain, that there is any kind of toxicity from levodopa to the neurons of the brain. We don't become resistant to it or anything like that. It's just that as we progress over time, we don't store levodopa as well because we have fewer neurons dopaminergic neurons to do that with. So levodopa doesn't feel like it lasts as long. And because our brain, we in Mother Nature, we've made dopamine pretty continuously. And now we're trying to, no one is very good at perfectly mimicking Mother Nature. I think, that's what we've learned. And so it's just that our brain recognizes, there are highs and lows. I need to be ready for those highs. I need to kind of adjust to that. But that is also not irreversible. And maybe I should have just led with that. So I kind of buried the tag there a little bit, because we've seen if you can smooth out, if you can flatten out that up and down, that fluctuation, that a lot of those, people don't have so much dyskinesia, or it may even go away. And there are other medications that can also help with that. So
are there, somebody asked if like NSAIDs or a taper of prednisone or creams, and I'm wondering if they haven't asked yet and I've missed it, but somebody's going to ask about CBD. Are some of those things effective in this?
Definitely, I think, so the NSAIDs and the prednisone and those things, I think they come back to the issue of there's pain along with this, and maybe especially for something like the cervical, the neck pain and spasm. I do want to make the distinction that when it comes to cervical dystonia itself, so which is just the underlying tendency for pulling and turning, and that's not necessarily going to be changed by an NSAID or prednisone or something like that. But maybe the irritation on a skeletal level, on the connective tissue level, because of chronic pulling and increased pressure on some of the joints there, that's the part that would be helped by those kinds of medications, as well as by stretching and physical therapy and what have you. I hear
a theme. I hear a theme of stretching, physical therapy, exercise. I hear this theme.
I know, as much as my not really as in shape as I should be body, is a terrible example. It is getting to be inescapable.
Yeah.
That exercise, stretching, and activity is the path forward for all of us for an independent and full life. So
right. Now, how about some people have been sending messages asking about some other things like if you were to take something like if you were using Duopa, or if you're using something like Rytari with like a more extended release that might help smooth out some of that dopamine release, perhaps. I'm using the word smooth out. I don't know if that's the right word. Would those kind of things help?
They often
potentially.
do. Yeah. I mean, so, and again, we're talking pretty specifically about Parkinson's here, in folks that have, that are encountering more, limitation or difficulty because of fluctuating, from over to under, and not consistently being able to stay in that, kind of their sweet spot, if you will, in terms of their medications. And so we certainly see that, even with Rytari, which is still oral, but has kind of a way of being, of kind of time releasing in 3 different phases, so that you kind of avoid the big spike and you kind of just get a plateau that's stretched out of a longer period. That there seems to be a reduction in those, both the highs and the lows. And we see that in the clinic, that it can be very helpful. I would say the most striking difference, has been with something like Duopa, which is really, essentially, it is the ideal way to take levodopa in a way, even though it's a little more complicated. And I think a lot of people still are trying to get comfortable with the idea of it, as it's kind of delivered through a port, but it is the degree of change in, that I see in patients who have been struggling with dyskinesias and fluctuations, is so striking, in general. It may take a little bit of time to adjust and fine tune the dosing. And I don't know, I guess I should not assume that everybody here, that's listening knows, exactly what we're talking about. But this is the the levodopa gel that is delivered via a pump through a port in your belly, and it bypasses your stomach and releases it in the duodenum. And that's important because, number one, your pills, if you're going to have delays in your medicine working, it's because your pills are usually sitting in your stomach, not going anywhere. And there's no absorption of levodopa in your stomach. And so by bypassing that, you skip one of the big disruptors of continuity. And then from there, you're directly infusing it into the jejunum, which is the beginning of where our maximum absorption can happen. So it really is as close to giving somebody an IV of levodopa as you can get, or it's the next best thing. And that's what's so remarkable about it.
This is all so helpful. And someone sent me a message here asking about, I think it's this delicate balance. Somebody asked about that they feel like their doctor really tries to get rid of all of their dyskinesia at the expense of then feeling really rigid. And I'm thinking that this, with each person, right, there's no standard way. And with each person, it really is, it's about quality of life and what symptoms are the most troublesome to them. I don't know. I'm wondering if you can, as you think about how you practice, and I'm feel very fortunate to know you really well. You really focus on quality of life and what do you want out of your life, and let's get that. And I think I'm going to just say to the people that are writing me messages, and some are sending me private messages, that partnership with your doctor is so important. And so if you have a doctor who you're saying, yeah, but this is bothering me, find that this is cured, but now this is a problem. If you don't have a doctor that can hear that, it's okay to get a new doctor. Your doctor has to partner.
Yep, and I think it's good. As always, I'd say the first step is if you're struggling, if you're finding like, oh boy, they're so focused on this, make sure that you've voiced that to them. I see it, and over the years, I've learned to actually ask at the towards the end of a visit. Now, here's what I'm thinking we should do, but what is that? How does that actually sound to you? And so, he or she may mean well, because they have maybe had experiences where patients were really debilitated by their dyskinesia, and so their focus is, oh my gosh, this causes so much trouble, I don't want to do it. But if but they may not realize, or they may not have fully heard you. So it's always worth making as clear, and I personally don't mind how blunt a patient is, because I'd rather know how tell me how you really feel is what I want to hear. And if I'm, putting a lot of energy into something that you feel is not working, I'd like to think most of us are, feel the same way here on our side, is I'd rather hear, what, I don't mind some dyskinesia, but what's making me crazy is I feel like half a person so much of the day, or, and I'm just tired of not being able to take nice, big steps, even though there was a time when I really could. So I know I should be able to. Yeah. And you're right. So I guess here's my philosophy is, Parkinson's, we're kind of stuck with it, right? Once we're diagnosed, we're stuck with it for the duration, until some genius comes up with a way of bailing us all out of that. And so you're potentially stuck with, that doctor that you're going to work with, that's a lifelong friend. So you deserve to have, the best possible relationship you can find with that person. And if you don't click, hopefully in most communities nowadays, most of us are not too far away from at least a couple of different specialists, or at least really experienced neurologists with an interest and some expertise in Parkinson's. And so, you know, I for better or worse, you know, there are friends from high school and college that, you know, that were fantastic friends then, that we've grown apart and we don't stick together. And then there are others that I still talk to, you know, probably weekly and monthly, right? And so it's about finding the ones that are keepers for you. Mm-hmm. And that's really it. I think this is different than just having, you know, your doctor. This is somebody that's got to be your partner.
Mm-hmm. And I love what you say, like, have a conversation, because you do that at home. When people don't have a good connection or missing pieces, you hope you have a conversation about it. And I think that's just absolutely wonderful. You know, somebody asked a question. It's not tied to particularly the cramping, but it is something that they're very interested in. Exactly. Okay, so I'm gonna find it now, because of course I lost it.
Oh, sorry.
The question, no, you're good. The question is, how does fog fit into the realm of ailments and explanations? So that Parkinson's fog.
Fog. So, oh my goodness. So it is. Well, if someone out there knows, you're welcome to jump in too, because it is literally there are a handful of, you know, reviews recently that have come out about this phenomenon, and some of it, you know, some of it is fatigue, or often described as fatigue. Others, it's just described as slowness, or like that jello brain feeling, or that, or are we talking about, I just saw a comment, is it freezing? Are they specifically talking about freezing on gait? So that's a different thing, because I'm assuming, was that Nick Contas that sent the original question?
You know, I don't know. Nick does call it his dark passenger, he said, though. But I don't know who sent the original. Yes, okay. Actually, yeah. So yeah, go ahead.
Oh, so Nick, if it's freezing on gait, well, I will switch gears. Actually, I'll be relieved, because I wasn't going to have a great answer for brain fog. We'll try to have a better answer another time, maybe, for that. Freezing on gait.
Do a whole nother one on fog. Yes. How about that?
Yes.
Okay.
So the freezing on gait issue is, so some of it is certainly levodopa or dopamine related. So for most folks, they're going to freeze more if they're under medicated in that. But there also is a large component in the folks that have frequent, like where freezing is a regular issue or a recurrent issue, that where more levodopa doesn't really do anything beneficial for that one feature. And it turns out it's really kind of a geometry and engineering problem. And there may be other neurotransmitters that are important in this outside of dopamine, but we haven't really found from a drug standpoint, a surefire, drug to supplement with that always seems to help this. But there is something that happens when our basal ganglia isn't quite in balance, i.e. Parkinson's, that once your weight shifts a little bit off your heels and onto your toes, there is a short circuit of the whole walking mechanism. And it can be a difference of just a few degrees of forward lean. I see this in the clinic all the time. We do live experimenting here in the hallway with, all right, I'm going to pull your shoulders back 2 inches, and now you're going to walk again, and you are going to put your heel down first, and then and it's going to be heel to toe, and we can do it. and then, we'll take away the cues and we'll walk some more, and that body will just lean a little more forward, and boom, we're right back to stick, 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 that staccato. And suddenly, the chin is getting further and further out ahead of the body, and the feet are not going to keep up. And that is where people, are running into things, or they are sort of almost falling forward instead of running or walking, and it is a very frustrating and scary experience, as I understand it, and as I would imagine it myself. It is probably the most frustrating motor symptom to deal with, and yet it's another one of these ones where if we could just somehow do everything perfectly, it's theoretically overcomable, but it's so hard to keep all of the little steps in your brain, and then look up and say, oh, a bird, and then it's all gone because you're not thinking about it. That's the whole thing about the basal ganglia, is it's been doing all these little calculations for us without us having to think about it. And when it's not there working at its best, especially for the walking, it's so hard for us to actually think about each of those little bits of our posture, our balance, our stride, and all that at the same time, and sustain that without losing concentration and thinking about something else. I don't know if that's a very helpful, it's kind of a convoluted thing, because gait is a very complicated, convoluted thing.
Well, and I think that's part of it, isn't it? It is complicated, and part of it is frustrating. And like Nick said, face plant occurs. It is a big troubling, it's a challenge. And so, and we can, we're taking notes on, we always do take notes on these things when we hear people bring up topics that we think, boy, we could do actually another hour focused on that.
Oh, yeah, absolutely. This could be easily be a whole conversation, because there are things like, well, gee, do what is it, the negative lift shoes?
Yep.
Some people, those really, are really helped by that, because it forces a little more weight onto their heels. That was like a big thing with runners maybe 10 or 12 years ago, but it doesn't work for everybody, and it's again, it's this weird engineering thing, and we're all so different.
Stay tuned, because I think we might end up having a freeze deep dive, and we'll go freeze for moving, freeze for the brain, the different freezes. And I think we probably have time for one more. And Ava, I'm going to say your name is Ava. Could have been Eva.
The brain fog.
The brain fog, yes. That's a big deal. And I think, Eva, you had a question, or Ava, forgive me, I'm not sure exactly the right way to say your name, but had a question about the kind of the core tightness.
Can you hear me?
Yeah. Mm-hmm.
You can. Mm-hmm. So my question is, I get this grabbing tightness right through my middle, and everything clamps down, and it feels like I'm in a permanent sit-up. It's so tight, I have trouble breathing, and then it just kind of, everything clamps down. Is that rigidity? And is it just stretching and more dopamine that's going to help that? It's awful.
That does sound, and it's a good example that, these things I've been talking about feet and necks and things, but you have muscles everywhere, right? So, well, what you described almost makes me believe it's more of a dystonia thing. And I guess, so the first step for most people where it's an intermittent issue is try to frame it within your daily medication schedule. So, even if it doesn't happen, every cycle of medication, but when it happens, does it tend to be you know, in the first hour or so after you've taken your meds? Does it tend to be as you're getting closer to needing to take your meds? So if it's, you know, and that's usually your best clue of, is this too much? Is it too little? So in your case, I saw not, so maybe it's towards the later, the tail end.
Yeah.
And does it, you know, in a perfect world, if you say, gosh, it's happening at the, and I take my meds and on time, and about 20 minutes later, it finally goes away. Now that would be nice, because then it would be like, yeah. But for some people, it's already gone by the time they take their meds, and it's just part of their transition. So it might be that what I described as there's sort of dystonia, kind of, you know, and then or dyskinesia, and then things smooth out, and then they have dyskinesia or dystonia later in the dose again. And so it may be part of that. Oftentimes that kind of more core spasm type thing does seem to be, you know, more often than not, I guess I would say, does seem to be end of dose or a later in the dose type of thing. You know, and there are various ways to try to approach that. If you really don't have any other dyskinesia or issues like that, it might be a matter of, you know, trying a little shorter interval between doses to see, well, what does that do? Does that change? Does that eliminate it? Or if you're on, you know, depending on what formulation of levodopa you're on, and I'm assuming this is happening with that, you know, and you know, then maybe is there, can we try a longer, you know, a more extended release version of something, or could we add something that's longer acting? You know, we have, or something that changes the, you know, that slope of the medication in your body, like maybe there are COMT inhibitors, or there's an MAOB inhibitor, so that would be like, you know, like rasagiline or something like that, or what have you. So there's kind of different ways to play with the pharmacology, I guess, of what your brain is experiencing.
But don't you leave yourself open by adding more of the dopamine or the Cinemet to then have the dyskinesia?
Well, you know, so dyskinesia, there's some data that says, yes, there is a connection between like just taking a lot more versus less and having dyskinesia. But as we were, you know, as another patient had pointed out, you know, dyskinesia isn't necessarily the worst thing in the world per se. If you had just a tiny bit of dyskinesia and great mobility, I guarantee you would say, okay, I'm happy with that. Especially in comparison to not being mobile. Now, I say that, and the important thing everyone needs to remember is that is not the equivalent of not being able to sit in your chair, or, you know, or those things, or having that kind of dyskinesia. That's difficult for anyone, and that's certainly not our goal. But I think it's important to not fear any one thing too much. And what we're talking about here is not so much taking more medicine, but delivering medicine better. So it's really the ups and downs that are what play a role in the development of dyskinesia, is more so than the total amount you're taking. So what if you say, well, gee, I take, you know, 3 Cinemet 2 times a day, yes, that's probably a great recipe for developing dyskinesia. If you say, I take 1 Cinemet 6 times a day, that might not be a problem for some people, you know. So, and again, that's not going to apply to everyone, but exactly in that way. But
so less over more time rather than big chunks of it.
Right. What we're always trying to do is reduce the highs and the lows. We don't want the Alps. We want the Great Plains. You know, we want things to be nice.
Stay away from the mountains.
Yeah.
This has been amazing. There are so many great questions in the chat. We're tracking these. Kelly and I have been tracking these, and we will pull them to create some follow-up. Dr. Samanta, if you're up for it, we'd love to have you do some follow-up talks, and especially maybe with a few focuses on the different kinds of freezing, whether it be movement or, you know, something like the abdominal or in the brain. So wow, so much information. I'm gonna wrap us up just because I know you've got to get back to clinic and see your patients, but I will say that,
Get me back to work.
Yeah, please. Please, yeah.
I would love to be back on. So, you know.
Great.
You know, this is my favorite group to spend time with. So
this has been absolutely wonderful. Love visiting with you, and you guys can see, I mean, you're just such a wonderful physician and was such a wonderful person. So thank you for sharing your time with us. And boy, these questions were excellent. I mean, these were great questions, and they just show the complexity of this disease. And this is why we keep showing up to learn, because I think it helps us become more educated so we can ask these questions and have really good discussions with our doctors. And even if you don't live near a movement disorder specialist, while they might prefer to be able to look at some of this stuff by touching you, you can always still look at a movement disorder physician visit on telemedicine. May not be ideal, but it's certainly better than not having one. Don't you agree, Dr. Samanta? I know you do a lot of telemedicine.
We do, yeah. You know, and even there, you know, with everything, we always, when we can, we love to have people come in, but sometimes it's just not possible. And you know, and thank goodness for improved technology these days. So, and I've always felt like, you know, the biggest part of a Parkinson's visit is it's not. The exam is helpful, but with someone who's established, especially, it's our discussion about what's happened since the last time we met. And that's really what we're going to base our medication changes on. So,
right. And so those kind of things you can have, you know, no matter what, we want to make sure you're linked up with a movement disorder specialist. And yes, I can tell you for sure, Catherine, we will have him come back. We are grateful that he will share his time with us. We know you're so busy. Thank you for sharing your lunch hour with us. And if everybody can join me in sending him a big wave, I'm sending you a big virtual hug because I know you. I'm going to hug you.
Hug back to you.
Yay! Till I could see you in person.
Everybody that took the time to jump on and listen and send great questions. So
thank you.
Thank you.
Everybody have a great day. Thanks so much.
Thank you. Bye.
Bye-bye.
Bye.
Bye.